All right, well, let's go ahead and get started. I know we have a smaller audience today, but that's understandable. So this is our second talk of our new MSKC Research Chat series. I think everybody knows what the MSKC is, that is on here. But for the purpose of our YouTube video, we help incubate and foster research with military-connected communities. And Dr. Erin Anderson is a postdoctoral fellow between the Beckman Institute and Carle Foundation Hospital. And Erin is here to talk with us today about veteran brain health. So the title of his talk is Making the Invisible Visible, Brain Health of Heroes. We should have some time at the end for questions. I don't know how you want to do it, Erin, if you want to accept questions throughout or just wait till the end. Just up to
questions throughout is fine. You can either jump in. I also have the chat window open on another screen, so either one is fine.
All right, well, oh, it looks like we had another person log in from a phone. That's good. Oh, that's Ingrid. Why did you log in twice?
Because my audio doesn't like me.
Okay. I was excited. I thought we had another person. All right. Take it away, Erin. Thank you.
Thank you, everyone, for coming. I'm going to try and give kind of an overview of brain health in general, but then find out some specifics about military veteran brain health, some of what makes it unique, and also some challenges and opportunities moving forward. So what is brain health? This is usually sort of a broad term, also kind of difficult to explain. So I looked up a couple definitions from the CDC. They look at the ability to perform all the mental processes of cognition, including the ability to learn and judge, use language, and remember. This is fairly generic and definitely just kind of, can you do the daily processes of life? And the American Heart Association, which this is more geared towards aging, and they're thinking about just average performance levels for your age. So contextual to the age, like, can you do what is expected of you given your age? If you're an older adult, are you declining at a sort of accepted level? And then there's the last part, sort of adequacy to perform all activities that the individual wishes to undertake. So that's more of like just the difference between, are you able to do it relative to the average, but also, do you feel like you can do what you need to do related to your mental abilities? And then one that I think is a little bit more contextual and a little bit more, the language is a little bit at least more descriptive, from Brain Health, the Center for Brain Health at UT Austin. And this is focusing more on like this idea of wise decisions, solving problems, interacting successfully with others, and enjoying an emotional balance. So this one's a little bit, the language is a little more colorful, but it's also, I think, more descriptive of people and how they interact with the world. But they're also saying, are you able to do it? Do you have the agency? Can you think strategically and be innovative in problem solving as they arise? And I think this language is actually, even though this isn't military specific, it is in line with military culture. There's a strong emphasis on self-agency, problem solving, action, and grit. So like, can you do it? Can you take on the challenges that you need to? And I think this is going to be a theme that we see throughout in the concerns and the issues related to military brain health. They also had a nice graphic, I think, that gives that it is a holistic, there are lots of different parts that make up brain health. It's not very, can't really tie it down to just a couple of things. It is really the whole person. So if you think about these brain systems, and they show in the first ring, sleep and stress. And so sleep, and these are kind of just like the two ways you live your life. You're either in sleep, so you're sort of the idea of down regulation of your whole body and your brain and your body. But then as you're awaking, it's sort of this levels of stress, and not to make it seem kind of negative, but it is just throughout your day, you're responding to different stressors in your life. And the cognition part is your complex thinking and specific thinking. So you have little linear things in specific cases, and complex, you're trying to build them together. So it's more complicated, taking multiple inputs and you're putting them together, and can you handle that? Interaction with other people. Can you do your social engagement, support, well-being? It's more of how resilient are you? Is your mood? Can you control your mood? Do you have a general quality of life and a purpose in your daily life? Are you taking care of the little things that compound over time that affect you kind of more in subtle ways? Your exercise, your nutrition, these things. So if we think about this as a veteran brain health, there are a lot of different conditions that are very typical of veteran brain health, including traumatic brain injury, post-traumatic stress disorder or syndrome. Even those two parts are kind of dropped off now. Depression, anxiety, neurological degeneration that is inconsistent with normal aging, among many other. And those symptoms can be both short-term and long-term, and they can be specific and non-specific, and that makes all these problems all that more difficult, because it's not so much like a broken bone or something where it's, it's happening, the short-term and long-term expectations, and it is very specific and you can move forward. But because brain health is so complex, like we just talked about with that graphic, it's because it's affecting different things in different ways at different time periods. So you can have headaches, sleep disturbance, mood changes that aren't necessarily controlled, memory issues, you're having social problems, visual, etc. So brain health is very broad, unfortunately, in a lot of ways. So you got to figure out more what you're talking about and make it specific. And how do you manage the idea? So we look at one of these areas, concussion or TBI. In sports, there's usually an analogy between sports and military because in a lot of ways they're similar. So they have in sports two of the main diagnostic ways you think about how observing it is the Sports Concussion Assessment Tool, or SCAT, which is in version 5. Impact, which is another similar set, but this one is automated and normative, some differences. In the military, you have similar things. You have the Military Acute Concussion Evaluation, or MACE, which is in version 2, and the Concussion Management Tool. Both of these were written by similar authors. So a lot of consistencies because they are written by similar people. And as you can see, this is just the first kind of pages of looking at it. What are some of the things you're looking for? You're looking for timing. So are you doing this within the first 24 hours, but you can do this up to 7 days. And you're monitoring people in the first 24 hours, 48 hours, and how are their symptoms progressing. But unfortunately, these management tools are really assessments that are guides. They're not necessarily diagnostic. They can't definitively determine that you have been diagnosed with a concussion, but they're helpful. And the problem is a lot of these is scoring these, how you're doing it is what's normal for that athlete or soldier. And normative values aren't always available. And because you're looking at across multiple different things. So it's some of the different areas of symptoms you're looking for cognitive dysfunction, vestibular dysfunction, ocular motor. And then you're also looking at different categories of symptoms like headaches, migraines, anxiety, mood, sleep, cervical spine. So you're trying to pull together all these symptoms and categorize them in a way that's going to help you improve. Just like, are these symptoms consistent? But they can be confounded by, do you have a history of headaches? Do you have a history of ADHD that's going to affect your ability to actually perform on cognitive tasks or vestibular tasks? So it has to also be specific to the person, which is difficult to do. In that clinical workup, as you saw with assessments I just mentioned, but also there's imaging. So if you're near the capability to have clinical imaging like a CT or an MRI, they can give you they tend to be able to give you gross issues. So gross meaning like you can see a bone's broken, you can see a bleed very clearly, but a lot of times these are maybe not as specific. But if you're having these persistent symptoms and they're specific, say, to memory, then you're going to do a much longer neuropsychological workup, and these can be hours of testing, because really then you're trying to say, like, how can we assess go deep down and look at these symptoms and deal with them. So there's similarities here with sports-related concussions. These are repetitive hits to the head. So lots of blast injury, multiple blasts over training is similar to football. You're hitting your head with with other athletes. And the immediate and long-term symptoms are very similar. So you have that motor vestibular dysfunction, vision, judgment, memory. These are all symptoms that you're going to see if you're having these issues. And the diagnostics and treatment plans are pretty consistent as well. You're testing similar symptoms. Your treatment plans are pretty similar. But again, there's no definitive diagnostic for either category. But there's a lot of uniqueness of TBI in the military. Compared to sports, there's no sideline on the battlefield. You can't just pull off to the side and get checked out that easily. It doesn't work that way. And even in training, you're not necessarily able, for a number of different reasons, to just kind of check out and go look, as opposed to if you had like a torn ACL, much more clearly you have something wrong. And in the military culture, there's a lot of distrust of authority, at least in terms of healthcare and these things. And they don't want to let down fellow soldiers, so they don't want to be seen as the person who can't keep up. So you want to keep moving, and they're just saying it's just a bump on the head. How bad could it be? There are a lot of consequences, though, if you're not treating these and taking these seriously. In the active duty, you're putting yourself and others at risk if you can't actually actively, do a good job of diagnosing and treating. And in the veteran level, you can't perform better tasks, your relationships suffer, job performance, all these things more subtle, but are eating away at your quality of life. And also how the injury occurs, you can have that primary blast. So a lot of these are very different from sports related. And I'm drawing this conclusion or kind of comparison between sports and military because, at least in the researcher side, sports is a good analogy to bring across between the two, but it can fall short a lot of times for some of these things. Their blast injury is different than helmets hitting each other on a football field, and you can have secondary blasts like shrapnel injuries that are not just one injury. You can have multiple injuries within the same event, and then also that blast, the sloshing of the head, which is actually about one that's consistent with sports related injury. So 3 different ways to be injured, and one of them is really the main similarity for sports. And then if you're, in the case of usually shrapnel, if you have a traumatic brain injury, you have post-traumatic epilepsy, so epilepsy coming from that injury. And as you look across 100 years about warfighting, the rates are in the 30% pretty consistently 3 to 5 years out after injury. So there's really been no rate of a decrease, even though warfighting has changed over 100 years. And also it doesn't seem like the treatments have gotten that much better. And again, the difference here being it's more likely to have a penetrating head wound in military than in civilian life. And so if we look at across the DoD over the year from 2000 onward, and these are both, so this is including playing sports or recreational, military training, and military deployment. So all the traumatic brain injury across the DoD. So there's not categorized in any other way. So we're seeing obviously an increase given the post 9/11 warfighting that we have now. But then there was a decrease in about 2012, so it seemed like it was getting better. But still, these are high rates within the DoD. And these are only showing if you've ever had one ever. So 1, 10, they don't count them any differently. You're only showing for 1 for a specific soldier. And in the case of severity on the far right, from mild, moderate, severe, they're only counting the most severe case. So they're not actually breaking that out across multiple anyway. So unfortunately, the statistics here are fairly crude of what's actually going on. But obviously the Army is the largest, is also having the largest number across it. And just breaking this down, that it's not just active duty, the guards and the reserves are also affected by this. This is true across all the branches. I just pulled out the Army in this case. So they do a little bit to, break out some of the numbers here about how where they were, if they're active guard reserve, but that's kind of what we have. I'll just provide some context. So in thinking about this and what we can do locally, we developed a questionnaire survey to try and assess local issues related to brain health and what we might be able to do. So the assessments included a World Health Organization quality of life, just to get a broader snapshot. But then we focused in on what the National Intrepid Center of Excellence and NICO does for concussion management within the DoD, and also the Marcus Institute for Brain Health, which the director there was the founding director at NICO. And so using these standardized assessments to get a snapshot of both Champaign-Urbana and Illinois and across the country, but we're focusing locally. But also including background demographics, both race, ethnicity, but also military service and deployment history. And then getting an idea of what is your exposure like, so that health background. Can you provide a little bit more context than we were getting from the numbers from the DoD, and just like a head injury existed? Can you tell us a little bit more about that? What sort of exposure were you dealing with? Where was your exposure? Is it subconcussive? Are we getting some of that? And also post-traumatic stress disorder, are we getting, what else can we learn as sort of not just the injury, but some of the after effects from TBI or just from service, and general mental health. And so here we're working with Dr. Alston, the director of CHES, Dr. Honeycutt, Liz Spurlock, who's an undergraduate, and IHSI and CHES Brain Health Scholar from the summer, and Kirk Hauser, one of the local community leaders, veteran community leaders. And so we're actively recruiting. We do have some preliminary data that I'm going to share. So if you see in the bottom here, we have go.illinois.edu/vet brain health survey. So this is also for active duty, reserves, retired veterans, and caregivers as well. So we're trying to get a full breadth as much as we can of people, because as I'll come back to, caregivers are really integral to understanding brain health in veterans. So I pulled out a couple of things that we looked at so far. One of them was a dizziness handicap inventory. And for here, we have 71 people who responded to this. There's 25 questions that give us an assessment of just throughout your day, how are you dealing with different things like vertigo and disorientations and dizziness. And they're across how they're affecting your physical ability, emotional and functional, because the brain and the nervous system is affecting all these different parts in different ways. You can both look at them in categorically and then together. So we have on the left here the physical, and this count is looking at how's your score across all 25 of these. And it's on a range from 0 to 4 for severity for each question. So you're seeing a lot of people scoring in the zeros. So people are, it's not like everybody's having issues with this or something, but you're seeing a pretty wide spread of issues throughout. And it's affecting, it's not just physical, it's not just emotional or functional, it's across there. And you're seeing that it is affecting people and broadly, unfortunately. And so this total score is, I was just putting all these together, and out of 100, so the 100 would be complete maximum perceived disabilities, it said. And again, you have a lot of zeros, which is good news, but you are seeing a spread across here where there are a number of people who are being affected just in dizziness across many of the things that we're talking about. This is used to track, so this would be a snapshot before coming in for a clinical intervention or a research intervention, getting an idea of what they are, and it is able to give us at least a self-report of how they're feeling as they maybe improve with time or degrade, and hopefully an intervention is improving. The other one's the PTSD checklist, which is military specific. So PTSD, there's multiple versions. This one is military specific to get more contextual. And on the left, we have, they break it up into how you're feeling weekly across month and monthly. So 2 different time frames, because symptoms aren't always happening on a daily basis or within a week, but also across months. And so again, we have 71 here. And if we look at count on the weekly and the monthly, there's sort of a diagnostic cutoff at 30 to 31 is the guidance. So right in here, you're seeing that there's, it's split maybe about in half, a little less, but a significant amount of people are above that 31 to 30 cutoff for being concerned. And then if we look at, if we break these down by, on the left, we have score, so just raw score, and severity. So the scoring is adding them up, and the severity is looking at how many of these questions are you saying is moderate to severe. So and we count up how many of those are moderate to severe. And then we look at a combined score. So these are two diagnostic criteria of 31 to 33 cutoff here, but then also how many of these people, in this case, that's the total count of people out of 71, are seeing both that for a significant number of moderate to severe responses, you're seeing it both in the score and the severity, and also combined. So you're looking at about 20 people who should be concerned that they have serious PTSD concerns and hopefully are being treated. And again, this is used diagnostically for initial intake for intervention clinically or research, and tracking it over time. And so one of the other parts we looked at with this questionnaire is a little more free form, so not just quantitative, but getting a sense for how what veterans are saying they feel like is a need within the community related to brain health. Okay, so some of the things I just pulled out a few of them here. Someone said diagnostic and treatments that include the whole family and living environment. So I said at the beginning, caregivers, we want them to respond, and what we're seeing is that it's not just one person. And we talked about this at the beginning, brain health is social. It's how you're interacting with other people, it's your environment, what are you doing? And you get a more objective response. All this is a lot of subjective things, and we should also ask caregivers to respond to these things, because self-awareness, not just in the military, not just with brain health, is not that good. People aren't very good about assessing where they're at, and so having other people included in that is really important. Somebody else said, don't just treat veterans as data points, and Jenny has been championing this for a long time, that we're not doing research on them, it's with, and so this is echoed, and we didn't ask, so we don't tell them ahead of time, but they're responding to that. And also, I think in the bottom left here, this openness to more experimental procedures and the idea of this integrative therapies. They're responding to the kind of standard of care clinically right now, which is both in the VA, but also in private, outside the VA and civilian clinics, it's fairly structured, fairly rigorous, and there's a reason for that. Research came, and clinical practice comes from a lot of large studies. But these people are looking for things that are now, and what can we try, and be creative about some of these things. So it's important to pay attention to. And then also they said, understanding the whole complex, multifaceted military subculture can affect mentality amongst the service members. And that's saying a lot. It's just saying it's not only is this brain health really complicated and interconnected, but layering on top the military culture is affecting the whole thing. So we have these really compounding, which makes the whole thing very complicated. And then we also asked, what's your response to the idea of and being involved in research? What do you think is important? And so one thing that I will say I don't see as much, I see a little bit, but not nearly as much in civilian research, saying allow more of an open environment. So they really want to say, can you understand the veteran? Can you understand what they're going through? They're comfortable, so that they feel comfortable engaging. And that seems to be really built in this trust that they're not going to be judged for their issues or anything, because they can be really judged within the military community for, having feelings that are not manly, or, something that's, can I be comfortable? Can I express what I feel and what's going on? And also talk and actually listen to caregivers. So again, this is coming back up. The caregivers are really important to the whole process, because they're the ones advocating, they're the ones checking in and finding out. And so this one's on the right here is more of a little call to action to Ches, which was somebody saying like advertise. Like, I don't even, where did this come from? Like, you're asking me to do research. I didn't even know this existed in town. And supposedly there's this building and this idea, like it's a whole institution and staff and resources. And they're like, I didn't know anything was going on. And they're staples in the community. So that's important that there's partly just a public awareness campaign, I think, that needs to go on all the time, whether it's an active specific study or not, is you got to keep engaging all the time to keep that community up. And again, at the bottom, increasing the community-based participation. So it's really building that community on an ongoing basis to do anything. As I said, this recruitment for this survey is ongoing. We're looking to get a few more in before we can publish this work and use this to inform research going forward. We'd like to get some more responses so we have a better idea, make sure we're capturing it. And the goal is to capture issues and the needs of veterans with an emphasis locally so that we can help people locally, and also to create a veteran engagement team as an advisory group to research to ensure that CHES and the broader campus community is interacting with the local community effectively and respectfully. And again, building that trust with the veteran community. And in the future, is this data inform future research projects and directions and help researchers on campus who are saying, I think there's an issue, and being able to provide them a little bit more context about the specific problems. And also as a model for, so this is really a pre-intervention sort of snapshot that we could use ongoing. If same people come back and we do intervention, we have that data readily available saying, 6 months ago, this is where you were at, we'll be able to do it again and then do intervention. We're helping understand how that's progressing with time. And also improving coordinated data across campus because what we've seen for other community issues, whether it's around a specific disease or group, it really helps when you can coordinate some of these efforts. So just to close here, veteran brain health is obviously, I think you already knew, but it really drives home the point that this is important and it's also unique. So a lot of challenges. The type of brain injury, if we're talking about TBI, can be different. The location and severity can be different than civilians. And symptoms are both subtle, complex, interconnected. It's also physical, cultural. I mean, it's a messy, unfortunately, situation, but you really just have to pay attention to these things and do what you can. And the need for research is significant. The VA, as always, I didn't, go into that too much because I don't really want to bring, down too much, but there's a lot of distrust, feeling like the VA clinical practice is limited, and what's required is research to drive these things forward. And the military culture is something we have to pay attention to. Not that's any surprise to anyone on this call, but I think it's important to keep talking about it and make sure we're listing them out and keeping it on the front of our minds that they're skeptical of institutions, the DoD, the VA, and what I didn't put, but I should have, universities, really any sort of large scale institution are very distrustful of for obviously important, obvious reasons. They're skeptical of researchers individually, but we also did see in the response that they're willing to engage. As long as they're engaged respectfully, they will be helpful. They will want to do it because they know they have problems and they want a solution. So of course, they're not going to just refuse help forever. That would be silly. And the entire engagement process needs to be cognizant of military culture and needs to be back and forth and continuous. You can't have these dip in, dip out sort of things. It needs to be a continuous process. So that, thank you for coming, and I'm happy to try and answer any questions or field comments or suggestions, and go take the survey.
Thank you, Aaron. Super informative. Questions that anybody has for Aaron? You can use the chat box, or you can just unmute yourself. I know I have one, Aaron, around, I know we're right at time, so we'll maybe just take a couple of questions. I had one about post-traumatic epilepsy not really changing since, what was it, World War II, World War I?
One.
Yeah, in terms of, the prevalence of it, treating it. Can you speak a little bit, or try to provide some insight into what's going on there, or why that hasn't changed?
So in a lot of ways, epilepsy in general has a lot of difficulty in treatment, diagnosis, before you even get into the specifics about military. So there's been a lot of intervention, a lot of things, but even across it's a difficult thing because it's encased in a hard skull, and it's hard to get at, and it's hard to do interventions that are, ethical, and are, because you have such a precious time there. Specifically related to veterans in those studies that I do, the follow-up across, 3 to 5 to 10 years is difficult. So you have survivorship of interest in research. So people with the more severe cases. So there's a little bit of a bias towards the people who are interested are going to stay involved in research. So you have a little bit of a positive shift towards rates that are going to increase. But there's also, it's one of those things that's difficult to recreate that experience. So as a researcher, you want large scale numbers to help you identify something and be able to characterize it, which is why I was brought up sports as an analogy to try and use so we can kind of blend across. But in the military, you get deployed, especially World War I, World War II, you get deployed once, you come home, and that was it. It's only since 9/11 that you see these multiple deployments, so you can get a little bit more of this repeated, how did you change across deployments maybe? And so you get hit once and that's it, and you're out, and you go on. The other part is the timing. So when you actually develop epilepsy can be 6 months, a year, 3 years, 5 years. Like, you can develop epilepsy across that. It's not this immediate, you get an injury, you get epilepsy, or you don't. And so the timing, the lag there is really difficult to capture. So if you're going to do a study, you'd like to get everybody at the beginning to get a TBI so you could track them for years, but logistically, cost, so it's just been difficult to actually get that, enough information to make a change and to learn enough about it.
Yeah, this is a hard area, I think, to move research forward, and in general, just the topic of veteran brain health and how interconnected and complex it is, as you talked about in the beginning.
Garrett, did you have a question?
Oh yeah, I actually 15 years after my injury, I developed the post TBI epilepsy. So that's just a one point to that. So that was until 15 years after my injury that I started showing signs of epilepsy. But also, do you know much about the damage when they autopsy the brains in like military and autopsy the brains in like concussions in the NFL? The bruising in the brain for the military is much tighter grained than it is like in the like an athlete would be. So the damage is, it seems like it's more deeper and more involved in a concussion type blast from a bomb.
That's interesting. I didn't know that. Yeah, it makes sense because they're experiencing similar but different injuries. So it makes sense.
That really highlights, I think, the uniqueness, how unique every individual injury is when it comes to TBI, which makes it so hard. That's part of what makes it so hard to diagnose and treat it. Yeah. Any other questions or comments for Aaron?
Yes, Ingrid.
Ingrid, you're muted.
I did that.
Your phone is muted. Hold on. I
Okay.
can't. Maybe somebody else can unmute you, or you can. It shows that your phone is muted.
I asked to unmute your phone, Ingrid. Oh, I think she's typing it, maybe.
Can you hear me now?
Yes.
Yes.
Okay. Does it make a difference in terms of the time of injury and intervention in terms of success? So an intervention closer to the injury versus later?
Yeah. So if you get it closer, you're more in that active phase of recovery. So unfortunately, if you're waiting too long, the damage may be done and it's harder to reverse. It's similar to like, say you have an issue with a bone or a muscle. If you don't actively heal that at the time of injury, you're much more likely to have scar tissue or something else it's harder to deal with later on. And so in the brain, it's very similar. Say for in the case of post-traumatic epilepsy, a lot of that is dealing with, you say you have a vessel in that's broken and you have blood that goes into the area. If your brain's not able to clear that, because it's a toxin, blood in the brain is a toxin. So once you've done that, if you can't have a clearance system to get rid of that, it's just going to sit there and it stays forever. There's really no good clearance system except right at the beginning to get rid of that. And so there's a drug out now, I think it's gone through FDA approval, it's very close, that's actually actively targeting that clearance mechanism at the beginning. So that once you have an injury, you take this drug and it improves clearance of toxins. So yeah, timing is really important.
So does imaging pick up old injuries versus newer ones?
Yeah, so because that, in the case of blood, it's because it stays there, you can actually see that over time. And so there are, with MRI, there are imaging that is specifically targeted for blood. And so you can you're like highlighting that blood. And so people look at that for aging as well. So, or other injuries where you have vascular, so in aging, it'd be like vascular death, and like in TBI, vascular injury. So anywhere in case, and you can see that. So in aging, you just tend to deposit that over time. And then in like a specific injury, you can actually sometimes see that. Now, how good is the imaging determines what size of injury you can see. So that's sort of the challenge when it becomes, it's there, but you may not be able to see it. So plug for the new 7T MRI that's coming. Well, it's effectively in place, but it's not on yet. So that will help. So.
Would an early intervention be the barometric pressure chambers, or is that just like, how good is that? I was just with in Indiana doing a speaking engagement. In Indiana is doing a great big study of doing those studies for veterans with TBIs.
I have heard good things about barometric pressures. I don't have a lot of, I don't know a lot about them, but I do think that it's anything you can do to improve healing and that's what basically, it's improving your body's ability to heal. And so barometric pressure would be one of them. Obviously the logistics, I think, is the one that always comes back for the uniqueness of the military. You're gonna are you gonna get a bunch of barometric pressures on a C-130 and fly them into Baghdad? Can you get people from Baghdad to Germany or something, maybe, or something? Because that's where most of the imaging is. And so I think that's the, what can you do locally is the other major complexity with military. So,
and you got to spend in a chamber for like an hour and a half. So you have to sit there, and that would be a huge disadvantage for combat, especially to like, oh, hold on, I got to go to the chamber for 2 1-hour sessions today with a 4-hour break. It's just not, it's not doable.
Yeah, exactly.
It does your question does make me think of the qualitative comment you had up, Aaron, about veterans looking for more integrative, sort of non-conventional, holistic, options. And I think that is encompassed in that.
If anybody was there, which I think most people were here.
10 minutes.
Yeah, just talk to Jake Zwig if you want to talk about integrative ideas.
Oh, he's an expert.
Yeah, just after Jake. All right. Well, thank you again, Aaron. We appreciate all your insight. And our next talk is about a month away. It's the first week of December, so we'll be sending out information about that. And if you have not taken a survey yourself yet, please take it and please share it within your networks. As Aaron said, we're recruiting for this, and we'll have much more comprehensive data in the months coming up, and we will release that when we have it. So thank you, everybody. Have a good rest of your day. Hang in there.
Thanks. Yeah. Bye.
Bye.